Okay, so today we will have a quick review of liver. Uh, It's also one of the most important topic which is frequently asked in exams. Okay, so when we talk about liver diseases or things to know about liver, uh, usually liver has some synthetic function. Okay, liver has some metabolic functions. So whenever we are just thinking about it, or if we are you can say that when we are considering liver damage, so either it will be problem with the synthetic function or metabolic function, or if there is hepatocellular damage. Okay, so certain enzymes will be increased. Okay, and as the like with reference to you can say ALT, AST, okay, and gamma GT, they will be raised. Okay, so this will be one point. With reference to synthetic function, all the like coagulation factors, so the effect will be on the PT, APTT, INR. Okay, and also the albumin level will be reduced. So these are few uh, practical things whenever we are considering any patient with liver damage. You will be considering this thing. Then, and there are some like problem with reference to obstructive, whenever there is a bilirubin, okay, it is raised, whether it is indirect or direct, okay, and so if there is any obstruction in the biliary tree, then it will be in the form of obstructive jaundice, and uh, alkaline phosphatase will also be raised. Okay. So in addition to the clinical signs and symptoms, so usually the clinical signs symptoms in liver problem are usually they are some non-specific nausea, vomiting, okay, diarrhea. Then if there is uh, like uh, uh, severe damage, so it will have jaundice. Okay. Then if the synthetic function is disturbed and there is coagulopathies, so bleeding can occur in the form of either hematemesis, okay, or either with like you can say that it either in upper GI or lower GI. It can cause either melena. Okay. Then in liver failure, what else usually happens is, for example, uh, ascites. Okay, ascites occur because of portal hypertension. So this thing it should be in your mind. Then in also in like uh, chronic liver disease, there is a phenomena which occurs is hepatorenal syndrome. Okay, and one phenomena which is hepatopulmonary syndrome. So and another the patient can go in encephalopathy. So these things should be in your mind. And with reference to anesthesia conduct, in addition to all these problems, which the thing which will all the anesthesia medication, they will have metabolism from the liver. Okay, so metabolic problem, and so there may be either a prolonged effect of some medications. There will be some damage further. Like for example, one example is paracetamol. Okay, so there will be some problems with reference to medications which are metabolized by the liver, and there will be some uh, anesthetic factors or medication which can further exaggerate uh, the liver problem. So you can say that there will be something which liver will be affecting the anesthesia. This will be one point, and anesthesia will be affecting liver. So these are two things. So you should be concentrating separately these two things. So now coming, because whenever I'm just giving you a bird eye view, so whenever you are having a even because the scenario which will be coming to you will be that a patient with liver damage, okay, which may be a simple acute liver problem, or there is chronic. So it will be either this thing. Then you will have to look at the cause of that damage. So maybe acute or chronic, and also you should be thinking whether it is some infective cause or some inflammatory cause, or like there are so many causes of liver damage. Even problems in kidneys and problem in heart can also lead to liver impairment. Okay, so you will be just looking at the cause and the damage. So usually there are in addition to the general sign and symptoms, there is one score which is being used for severity of liver disease. So whatever evaluation, like in the table Viva, when they're asking you, so you will be saying that how bad is the liver damage, whether it is acute or chronic, what is the cause, and if you want to stratify or quantify, or you can say you want to see the predict the mortality morbidity, you will be doing the Child-Pugh score. Okay, so there are certain things which is you will be bilirubin and encephalopathy and albumin. Okay, and INR. Okay, and what I'm missing, uh, bilirubin, encephalopathy, ascites. Okay, albumin and ascites. So yeah. So with this, yes, thanks, and thanks for your. So in with this parameters, you will be quantifying. So whether it is A, B, or C. So whenever you are
SIT, sir.
yes, I have written SITs. Okay. So whenever you are quantifying them, you will say that whether it is Child-Pugh A, Child-Pugh B, Child-Pugh C, and whatever optimization will be that you try to push C to B, B to A. If it is A, don't let it go to B. If it is B, don't let it go to C. So this is the basic principle which you have to follow. Okay, and there will be certain correctable things which you can do any if in any patient going for liver any patient having liver failure. So either you can, like for example, of course, in addition to correcting the correctable factors, you can drain the ascites. This is one thing. You can give some albumin. Okay, you can correct coagulopathy with FFPs. So this is just basic. Then other thing is that you can avoid or treat some factors which can lead to encephalopathy. Okay. So like you can say selective digestive tract decontamination. So this is one of the factor which lead to encephalopathy. So first of all, you will be quantifying or seeing the severity of liver damage. Whether it is usually in clinical scenarios when they are asking, there will be a patient with end stage liver disease, which they will be asking, coming for some either emergency procedure or some planned procedure, which you like. For example, if there is patient is having gallstones, okay, and patient already has cirrhotic liver, you cannot delay cholecystectomy forever. You will just try to have an optimization of the condition, and you will have to do the surgery. Of course, emergency surgeries can will have to be done at any cost. So you will just find a window that you will say that I will evaluate on the basis of history, examination, and investigation, how severe is the liver damage. Okay, and you will try to see how much time you have for the optimization, and of course, emergency surgery you have to proceed, and you will quantify with this the Childbox score. Okay, and then you will proceed. So this is basic principle which you will have to follow if this is being asked in table viva. Usually, you will be say that you will be expecting altered response of the medications, and I have a thing which I have mentioned to you a few minutes ago. So this will be one thing, and if the same thing is being asked as a like you have a long case in which you have to take the history and then do the examination and investigation, so actually your approach will be the same. Your approach will be the same. Another important point which will be there in all the scenario, and you can easily miss it, is infective, like you can say infectious disease. Like you can say chances of spread of infection if it is, for example, hepatitis B or hepatitis C. Okay. So this is very important. You can easily miss to tell that it will be an occupational hazard. And if you have a patient with liver disease, and the pathology is either because of hepatitis B or hepatitis C, that you will have to do the universal precautions, okay? And you have to be very careful not to uh, have the spread. Another part of the question they can ask you, because this will not be done today. It will not be possible to discuss this thing, but there is a like needle prick injury protocol. Okay, so how to proceed with it if you have a needle prick injury, but this is part of it, that on the basis of history, examination, investigation, and then certain things you will be considering. So if we just think just proceeding with our discussion, that what will be the challenges as an anesthetist you can face. So whenever you are thinking about it, of course the common thing which you are doing is thinking in the form of intra-op, post-op, and pre-op, but actually it is it is better that you think about different steps of anesthesia, like induction, maintenance, okay, and recovery. This is one thing you should be thinking. And all the medications which you are, like for example, pre-operative preparation, you can say, or you can say pre-medication. So this patient will be at risk of aspiration. Okay, a number of times these patients are at risk of aspiration. This is one thing. So you need to give the acid prophylaxis. This is one important thing. The other thing will be that you will try to avoid medications like, for example, rocuronium. Okay, it has excretion through both liver and kidney. So, and metabolism will be slowed. Similarly, vicronium. And worse is actually pancronium. Okay. So so better choice will be cis atracurium. This is one important point. Okay. Uh,
Sir,
Similarly, yes.
sir, why is this atracurium? Why not atracurium? एंड सर वन क्वेश्चन मोर कि जो हेपेटाइटिस बी सी है, क्या अभी भी उसका प्रोटोकॉल ये है हमारे पास कि हम हर सर्जरी से पहले वायरल मार्कर्स करवाएं, क्योंकि मतलब अब तो
Uh,
स्टराइजेशन प्रॉपर होती है.
Okay, I will try to answer. Aisha, there are some people who don't understand our language, so try to communicate in
ओके.
English. Okay, so actually
ओके
her
सर.
question is cis atracurium versus atracurium. Okay, this is one question, and the other part is about whether we should do hepatitis B, hepatitis C in every patient. Actually, it's so common that in elective surgeries, at least, you have to do. Okay, because it's part of screening. If they are
ओके.
especially, sorry,
ओके सर.
especially if you have a patient with liver failure, because the common, especially in our part of world, the because another thing which I did not mention is alcohol, because in Western world, a number of times the reason for liver disease is alcoholic liver disease. But in our part of world, it is there, but it is our in our part of world, hepatitis C and hepatitis B is more common. Okay, and remember one thing, your point is valid, but I don't think so. It's that much important. Okay, so when you are telling, it's always wise to tell the examiner. That you will be just looking at the etiology, because there are some relation with reference to iron, with reference to this copper. Okay, so there are so many reasons for liver disease, and so infective cause is one of them. Okay, I hope I answered your question.
Yeah.
Okay, so so this is because cis why, and another question, that why at cis-atracurium, because cis-atracurium does not release histamine. Okay, so these patients are a number of time vasodilated. So with reference to metabolism, both cisatracurium and atracurium are the same, but actually the most sweet of sweetest among the muscle relaxant is cisatracurium, because it does not release histamine. So this is one of the reasons. Okay, otherwise even the thing is that nothing, there is no absolute, because no, it will not be available in every part of world. Cisatracurium is not available in every hospital. So you can just say that if it is available, cisatracurium is a better choice. Plus, if you don't have, and you are using some other muscle relaxants, then you have to carefully do the neuromuscular monitoring. Okay, this will be another point. Okay, so this will be a challenging thing. All the procedures in any patient in which you are expecting bleeding. Okay, so all the, like you can say, central regional anesthesia will be a okay, tricky thing. It will be, you can say, relatively contraindicated, and unless there is a strong recommendation, you will try not to have. Of course, you can discuss that if there is no coagulopathy and the patient is stable, then you can perform. Otherwise, regional anesthesia will have problem. This is one point. The other is with reference to, for example, paracetamol and morphine, like opioids. So paracetamol is not contraindicated, but maybe you need to reduce the dose. Okay, paracetamol, because all the medication, even local anesthetics, they are also metabolized in the liver. So their metabolism will be delayed, and there may be more chances of toxicity. Similarly, among the opioids, the safest option is remifentanil. Okay, but of course, remifentanil will not be available in every hospital. So morphine may be avoided, because morphine has active metabolites. So if the metabolism is delayed and we have active metabolites, so morphine maybe will be not a good choice. And even when I was telling here, I forgot, I did not mention about preoperative enzyclisis. So actually, benzodiazepine or opioids might need to be given in titrated doses. Benzodiazepine may be avoided, because it can cause like a delayed recovery, as well as chances of aspiration initially, and it can also lead to, like, it can also predispose to encephalopathy because of sedation and everything. Okay, so you have to be very careful in choosing this answer. So you can just say, in addition, like a small dose of ketamine and dexmedetomidine, okay, uh, is frequently being used. So low doses of ketamine as an analgesic you can use. And if, for example, if there is a scenario like when you are dealing with such case, one of the scenario will be upper GI bleed. Okay, so in a patient with upper GI bleed, actually, if you have to anesthetize, they have to proceed with the banding or sclerotherapy or things like that, endoscopy. If in this case, if you need to intubate the patient, ketamine maybe needed, because you can, if you give a shocked patient a propofol or thiopentone, patient might not tolerate it. Okay, so because this will be one of the emergency scenarios which they can ask, that variceal bleed occurs. Okay, the patient is hypovolemic and patient is in shock, so there will be risk of aspiration, and this will be an emergency situation. So in addition to that sandostatin and all the medication octreotrides which they are using, or otherwise there is a Sangstein Blackmore tube. I'm afraid I have pronunciated correctly or not. So this is like one of the question which they can ask you in acute liver failure or chronic liver failure with variceal bleed. Okay. So, you have to think about it. Similarly, with reference to monitoring, in addition to the standard one, standard two monitoring, you can say that patient might need arterial line in if the patient is not stable, and patient like you need to have the monitoring of the invasive monitoring. Okay. This is another thing, and all the factors you will be avoiding to for like as I mentioned before, hepatorenal syndrome. Okay, so if there is hypoperfusion or there is like you are not able to stabilize the patient might go in hepatorenal syndrome. Okay, so in even in that case, monitoring urine output is very important. Similarly, hepatopulmonary syndrome, this patient have AV shunt and vasodilatation. Okay, AV shunts. So, like not every patient with liver disease will have the same scenario, but at least you have to rule out and you have to act accordingly. Okay, so and another thing which is that, for example, uh, overloaded high output states which is there in liver failure can also lead to cardiomyopathy. Okay, so you have to look at the cardiac status as well, because cardiac failure can also leads to liver failure, and liver failure can also leads to cardiac failure. Okay, because there will be generalized vasodilatation and overloaded state. Okay, so you just have to act accordingly. And also I forgot to mention about electrolytes. Okay, so usually in liver failure there is electrolyte imbalance, though there is already sodium retention, but because the volume is so much, so actually there may be hyponatremia. Okay, similarly hypokalemia. So electrolyte imbalance is also there. And so you just have to, and another important point with reference to ascites is that it will lead to decrease in FRC, and patient can desaturate very easily. Okay, so that's why draining ascites pleural tap will be a good idea in certain conditions to improve the post-operative outcome. Okay, so these are some of the points, uh, because this post-operative ICU care will be needed. Post-op ICU care will be needed. Okay. Uh, what else? Mm, okay. So let me just show you some of the text, just to just to s- just compile what we have already discussed. As I told you, that you should be knowing the cause of liver failure. Okay, and systemic involvement. Okay, hyperdynamic state, as I mentioned you, with reference to cardiovascular system, cardiomyopathy can develop. Respiratory, there is splinting, and also FRC will be reduced. Okay, uh, aspiration risk and pneumonias can occur. I have, as in this hepatopulmonary syndrome, actually, this is platypnea orthodeoxia. This is a very uh, like strange sort of that patient may experience uh, dyspnea and hypoxia when sitting upright, and it improves when the patient is flat. Okay, so hepatochem hematological I have already discussed with you. Okay, so fish They have mentioned some of the points here. I was just seeing that what else I need to explain to you. Conduct of anesthesia. Uh, because you can explore further various things like how to improve INR, okay, how to improve gastric motility, like any question? Okay. So, like you can explore further what you need to do for the improvement of the care. But general principles I have told you that this patient can have certain scenarios in which they can ask you in the exam whether it is like acute or chronic. There are basic principles which I have actually discussed. Yes, volume intravascular
ग्रुप करेगा नहीं
fluid
क्या नहीं करें
patient will be intravascular volume will be uh, like you have to careful monitor the intravascular volume. Okay. Mm, acute liver failure. Yes, there is one of the question which I was just thinking because they sometimes they ask what are the causes of post-operative jaundice. Okay, so one of the factor is the hip, like before inhalational agents like halothane was associated with like very bad uh, hepatitis. Okay, but other than that, if the patient is not having good uh, volume status or patient have hypotension, this will also lead to postoperative liver dysfunction. Okay, so in addition to other factors, you need to have a look on these things. Okay, so these are some of the causes of acute liver failure, like viral and some other toxins. Okay. Uh, Wilson's disease. One thing, another question which they can ask you is with reference to paracetamol poisoning. Okay, so any exam candidate at the moment? Neeta, you are going for exam?
Semi.
Yes. So Aisha, have you anything which because I was just thinking how to summarize it. I have tried to give you an oversight and the overview, the broad overview of the things which can be asked. Of course, pancreatitis is a separate entity. We will discuss with ICU topics. But usually, they will either ask you as a table viva, they can ask you as an end stage liver disease going for certain surgeries. So that will be one option. And these things you should be considering. You will stratify the condition and you will anticipate the problems. Okay. So this is one thing. And upper GI bleed, it is being asked many times. Okay. Uh,
Okay, sir. Do they ask about liver transplantation?
liver transplant actually least likely to be asked in the exam, but they sometimes they can ask that what will be what will be your role as anesthetist in as I was mentioning about paracetamol poisoning. So paracetamol poisoning, there is one scoring system, King's College
Things
classification.
criteria. Yes, sir.
So maybe this you they can ask you. Okay. And
And
if they, yes, you are saying.
and sir, MELD scoring. Do they ask about the MELD scoring?
Actually, whatever scoring, remember one thing, that you don't need to cram the whole of the formula. You should know that what are the parameters, because formula you can easily forget. When you have to recall hundreds of formulas, you can easily forget. But you should know which is the what you say, what are the criterias which are involved. Okay.
Okay.
In if you they it should be here. It should be written here in this acute liver failure. Uh, yes, you see, this is written this King's College and MELD score and MELD and PELD. There are two scores actually. A model for end stage liver disease and also for pediatric. This is not a book, Pradeep. This is article. Okay. So, uh, any other question you want to ask? Aisha, because in the exam, if you have a case of liver failure, okay, in as a long case, you will have to take history examination. And remember one thing, there was, I just recall, so I'm just telling you, one of the examiner, because abdominal examination is not finished without PR. Okay. So he forgot this thing that in these conditions, PR is not a thing. They were just trying to listen from him that usually we might do usually in the ward floor they people do even medical as physician they do PR, but in this scenario it will not be a very nice thing to do PR because if there is varices, patient can have bleeding, so it should not be done actually. So one of the examiner asked in our exam, it was not a very nice question, but he asked that did you do PR? And he couldn't handle the question. Okay. So actually, he just wanted him to say that in this scenario, it will not be a wise decision to do PR. This was the probable answer. Similarly, when they are thinking about they are just trying to probe the cause of liver problem. Don't forget blood transfusion. Okay, because blood transfusion is related to not only spread of infection. This is one point, and the other point is that it is sometimes also associated with like autoimmune hepatitis. Okay, so you just have to be careful when you are taking history, and also because these patients uh, can have multisystemic involvement. They so whenever you have a patient with liver disease, rule out cardiac, renal. Okay, so you have to evaluate all the systems. Okay. So these are the possible questions they can ask, like they can ask about hepatorenal syndrome. Okay. So diagnostic criteria, cirrhosis with ascites, creatinine, absence of shock, absence of hypovolemia, no nephrotoxic drugs, and still there is development of renal failure. Okay. In a patient with, okay. So uh, I will stop here. Actually, I am not feeling well today. You can easily sense I was just trying uh, to continue this uh, like uh,
Sir, one last question, sir. If you are, sir, able to
I,
answer.
I cannot recall. I have read about it. I have read your question. You don't. I will try to find out the reason, but there is association with blood transfusion and autoimmune hepatitis. Okay, I
Okay,
don't
sir.
remember.
Thank you. Thank
I
you.
don't remember the reason. I don't remember the reason, and I will try to. You know this is uh, a very good source. All the because thing is that even in the exam you don't need to prove that you have read which book. You just have to um, think that this is a very good chart to just quickly recall what happens in liver. So metabolic function is disturbed, decreased new gluconeogenesis. Okay, so like you can just see acute kidney injury, hepatorenal syndrome, hyponatremia, I forgot to mention about hypoglycemia because these patients are prone to have hypoglycemia, insulin resistance. Similarly, neurological, this hepatic encephalopathy, cerebral edema, and ICP raise, hematological bleeding and thrombosis, and INR. So you can just have a look on the link and prepare your answer. Like one of the question, how ascites develops. So there is one forward fold theory and one backward theory. So you should be just anticipating the questions. Okay. They ask also what is difference between prehepatic causes and the intrahepatic causes and posthepatic causes, direct versus indirect. These are the questions which they can ask you. Okay. So you just anticipate the questions and prepare their answer before, because when you are evaluating the patient, you should be anticipating what will be the questions they will be asking you uh, in like in line when you are taking the you are Aisha, you are for long FCPS, am I right?
Yes, sir. I'm for FCPS.
Okay, so for you, few more words, because in table viva, usually this is what I have told you is more than enough. Yes, in long case, they can ask you the pathogenesis of any of the problems, how encephalopathy develop, how hepatorenal syndrome develop, how hepatopulmonary syndrome develop. So you should know few words that you can just know, not too much details, but at least few words to explain how cirrhosis will occur. Okay, sorry,
Oh,
how cardiomyopathy can develop. So you just have to be careful, and all again the same thing. All the anesthesia steps keep in your mind, and because then you will not miss anything. Like if you forget anything, if you have a scheme in your mind that I have to explain each and every step, that whether which how will you give analgesia, whether the patient will go to ICU, which induction agent you should use, which fluid you should use. So you have to proceed like that. Okay. So I will stop here, and inshallah, uh, I will try to have another unit because actually the purpose I have discussed, like I mentioned again, I have discussed all uh, the topics before as well in various discussions. So you can just scroll through the YouTube channel, and you will find the liver. I will just uh, because liver is one of the most like frequently asked topic in both, or not only in long case but also in table viva. Okay. So the basic principle will be same. I will try to have because on Friday I will have more time. So maybe I was just waiting for Friday and Saturday for respiration and cardiovascular system. So here you can see where is liver. I will share you the link. Okay. So I will stop here, and inshallah we'll continue. Tomorrow maybe I will try to have some unit again. Okay. Okay, bye
टुमारो
bye.
सर कोई यूनिट है सर, बता दें कोई, कल
I
कौन
will
सा
I will
करेंगे?
share. I will share. Okay.
ओके सर, थैंक यू।
Bye bye.